Javed, you shared some sessions here on the last day. Tell us about what was at the end of the meeting and also what's in the future.
Yeah, so to Jim's point, this meeting was exciting because the session, late-breaking session on the last day, was the second last session on the last day of the symposium, and the room was really full. So that was good. So they presented a data that most of the people who are in the SGLT2 inhibitor world were sort of still looking for, and that is the effect of dapagliflozin, specifically in patients with peripheral arterial disease. There is still that issue with canagliflozin in people's mind. And the issue with heart failure is that almost all of our heart failure patients are on diuretics, and diuretics is a risk factor for amputation. And then you have the SGLT2. So now there are sort of two hits here. So interestingly enough, so what one would have expected is that patients with peripheral arterial disease have much worse prognosis than those without peripheral arterial disease. So that wasn't particularly a surprise. But then SGLT2 inhibitors actually benefited patients more, so that's fine as well because these are high-risk patients, so they benefited more. What was interesting was that there was no increased risk of amputation, and if anything, there was a signal which was favoring non-statistically significant, but going in the right direction. So at least we can rest assured that taking care of these patients well from their peripheral arterial disease perspective, there's no particular risk. Then there were a couple of really good papers from the Ironman study looking that age does not really make a difference. So that was good. There's a lot of discussion between in the iron world about what the best definition is. And there was some data presented that ferritin may not really be a good marker. So there was some discussion around that. What was interesting was that now we are sort of left with 3 studies, as you mentioned, that really makes us now excited about the future. So one was an Ironman sub-study about mode of death and what kind of outcomes were impacted. And it turns out that acute coronary syndrome outcomes, those patients that have heart failure, acute coronary syndrome outcomes got really better. Now, this comes at the heel of the pivotal trial in CKD showing less MI, and a firm trial in heart failure also showing more benefit in ischemic heart disease. So this story is really building up that IV iron may be good in ischemic event patients, and there is now a trial recently started in post-MI use of IV iron. So we'll see. Then Scott Solomon and the group presented the data on fine arts baseline characteristics. So we learned a lot about what to expect. This is a 6,000 patient outcome study, which is completed enrollment. So their baseline characteristics are a few really interesting factors. They included patients with EF 40% or more, which is different. Like all our HFpEF trials are greater than 40%, but they included 40% and more because most of the MRA data is within 35%. A good 2/3 of their patients are enrolled within 30 days of hospitalization. So they really have this worsening profile as well. So I think we will learn quite a lot. Their average BMI was about 30, and their NT-proBNP criteria was about, NT-proBNP was about 1,500, and about 45% were women. And I think HFpEF is predominantly a syndrome seen in older women, but because they went down to the EF of 40, one can expect that it was still predominated by men. Now, to contrast that, there's a lot of discussion that HFpEF obese HFpEF is a specific phenotype. So there are 2 studies with semaglutide 2.4 milligram weekly in obese phenotype. So unlike the previous study with fine arts, which is a large outcomes study, traditional study with an average BMI of 30, here the average BMI is 37 because the enrollment criteria is BMI of 35. And boy, these patients are symptomatic with an average KCCQ in the high 50s. And both the trials, one is the STEP HFpEF in non-diabetics, and then STEP HFpEF DM in patients with diabetes. One is a 500, one is a 600 patient study with a co-primary endpoint of quality of life and weight loss. And then the first hierarchical is 6-minute walk test. So these will be coming out later this year. So there was a lot of excitement built in this meeting as what to follow up with.
Wow, sounds really exciting. And Jim, circling back to drugs, another hot trial was Paraglide. Talk to us about this.
Yeah, there was quite a bit of discussion around acute heart failure as well, Mike, and several trials, including post hoc analyses from the STRONG HF study, which is acute heart failure, and then long-term follow-up of medical management, accelerated treatment. The Paraglide trial really adds to that discussion because there's knowledge that sacubitril valsartan has a role in heart failure with preserved EF, particularly in people with an ejection fraction that is not normal. And that's defined, depending on who you talk to, less than 60%, 57%, something like that. Also in women, in the Paragon trial, women had benefit across the wide spectrum of EF. So the guidelines actually give a class 2 recommendation for sacubitril valsartan in chronic HFpEF, but Paraglide looked at patients with acute decompensated heart failure with a normal ejection fraction, elevated NT-proBNP, and an ejection fraction 40% or greater. The primary endpoint of Paraglide was the proportional reduction of N-terminal proBNP after treatment versus valsartan. The study met its primary endpoint with an extra 15% added NT-proBNP above and beyond the valsartan arm. In addition, they had a hierarchical composite endpoint of clinical events and NT-proBNP lowering in a so-called win ratio approach. That was not statistically significantly improved, but there were 19% more wins in the sacubitril valsartan arm. This was a small study, by the way, only 233 per arm. However, in a pre-specified analysis, individuals with EFs of 60 or less had a even greater reduction in NT-proBNP, and the win ratio in this case was now statistically significantly in favor, 46% more wins in the sacubitril valsartan arm. The drug also improved renal outcomes, which is important when we're looking at the things that complicate our lives when we're taking care of people with acute heart failure, with an improvement in the renal composite endpoint. It is necessary to emphasize, however, when we look at safety and tolerability, as any clinician will tell you, there was more hypotension associated with the use of sacubitril valsartan, but also, as any clinician will tell you, we can usually work through that. So this was a win, I think, in terms of adding another piece of the totality of evidence supporting this drug for HFpEF.
Well, Jim and Harriet, congratulations on your late breakers. Javed, thanks for your great summary as always. And thanks to all of you for joining us here for this wrap up from the Heart Failure Association meeting at ESC.